I think it's just after 7 o'clock, so maybe we should get started, Lisa, shall we? And
Sure.
we'll have,
we can add in. Kiana and I can watch to see if anybody else joins in.
So maybe we'll get everybody to go on mute, and if you want to ask a question, just raise your hand. And I know Lisa and Kiana will be on the lookout for people raising their hand. If you want to ask a question in the chat bar as well, so if you're comfortable with using the chat function, you can do that. And Lisa, maybe you and Kiana can keep an eye open for the chat function as well.
Okay.
We're going to record this session as well, if you don't mind. So we're going to record this for other people to get this background view and behind the scenes look as well at diagnostic imaging. So if once we get started, if you're not comfortable in being recorded, you can just turn your video off if you like. So thank you for joining us today. It's another big milestone for the Dartmouth General Hospital Foundation and our Above and Beyond redevelopment campaign and project. We have a great tour for you today, a virtual tour, where we'll be getting a behind the scenes look at the new diagnostic imaging unit that just opened this week. My name is Steve Harding. Most of you know who I am. And I'm pleased to introduce Dr. Scott Mawdsley, who is the interim site chief, there's Scott, for the Dartmouth General. Dr. Mawdsley, hi.
Hi,
and
everyone.
also, I'll introduce Dr. Carla Pittman. Dr. Pittman is a radiologist at the Dartmouth General and also campaign co-chair. Carla was the campaign co-chair for the Above and Beyond campaign. You want to give a wave, Carla? And also Laurie Harding. So Laurie Harding is the interim diagnostic imaging manager for the Dartmouth General, Cobequid in the Tri-County region. So welcome, Laurie.
Hello.
Great, so they're going to be our content matter experts today, and they'll be the ones who can answer your questions as we get going. So again, Lisa and Kiana are here to help us to track people's questions. But before we start, I'll just turn it over to Dr. Scott Mawdsley. Maybe Scott, you can give us an overview of where we are in the redevelopment and what stage we're at and what's coming next for the redevelopment. Scott?
Oh, sure. So in terms of the redevelopment, everything's going very nicely, as we're all aware. COVID slowed us down a little bit, but we managed to get some work done during COVID, and we've accelerated back up to normal speeds now. So phase 1 diagnostic imaging was completed last week and handed over to the site as of this week. And the transition is going very well, and that's what we're going to talk about tonight and do the tour. So with the opening of phase 1, we've started construction on phase 2 of diagnostic imaging, and we can talk about that after we tour phase 1. In coordination with that, we're working on the ORs. So OR room 5, 6, and 7, we've completed construction in those rooms. Now we're waiting to install the equipment for surgery there. We're expecting that the booms, the lights, the electronics will be installed and ready for usage at the end of this month. So that's very exciting. The ICU space is under construction now. The opening for that is expected to be handed over to the site in mid-June and probably be operational in the beginning of July. So that's an important milestone. Once the ICU is operational, then we can start decommissioning the old ICU and start rebuilding that floor. So at that point, we'll start building the final patient ward and the intermediate medical care unit, which is expected to be opened in December, which will be the completion of this project and the start of the next project. Yeah, but everything's going well and we're back on track, and it's very, very exciting.
Great. Thank you very much, Scott. Great progress. So looks like our next tour will be of the ICU, the Lorraine Brown Rig ICU. Maybe in person, you never know, if we can get back together again in June, in late June or early July. Any questions for Dr. Mawdsley about the overall project before we get into diagnostic imaging? Any questions from anyone? Nope, great.
All right.
Thank you very much, Scott. Great work. So now I'd love to turn it over to Dr. Carla Pittman. Dr. Pittman will give a sense for what this new diagnostic imaging center, phase 1, means to our to all of our physicians and all of our staff, and to patients working, staff working and patients benefiting from this amazing space. And again, I want to give a big shout out to all of our donors who helped make all of this happen. These milestones are all because of donors like you who've really helped make this happen. So Carla, over to you. Oh, I think you're on mute there still, Carla, yeah.
There we go. So last week we moved over to our new space, which was the half of our department, which involves 3 new ultrasound rooms. So in the past, our ultrasound, we had 2 ultrasound rooms with 2 machines in 1 room divided by a curtain. And now we have 3 private ultrasound rooms, which is great for patient privacy and also for ensuring patients feel comfortable. We've opened our new registration and new waiting room. And I know you've all been to the Dartmouth General. So since we were built, we've always sort of managed to make use of every bit of space that we've had. And we had our waiting room in the hallway. And now we have a brand new waiting room with a beautiful skylight. And we also have a back entry and a front entry, so we can have our inpatients and patients from emergency come through a separate hallway as opposed to through the same hallways where patients were waiting. We also have a new area where inpatients and stretchers can also wait, which is great because previously they were in the hall. And also we've opened up our new renovated and new x-ray rooms, which gives us much more space, obviously. And they're also in there 2 new reading rooms for the radiologists, which from our work environment is a great improvement. And Laurie will give you a tour of all this, I think, shortly. So basically, the improvement in patient privacy is obvious and exceptional. The new ultrasound rooms, we'll have at least 1 new ultrasound machine. We're now fundraising for 2 additional ones. So our ultrasound machines were quite past their time, so 14 to 15 years old. So at the moment we'll have 1 new ultrasound machine, and hopefully in the future we'll have 3 new ultrasound machines. So not only will we have a new environment to do the images in, we'll also have state-of-the-art machinery. So I'll just mention that, so the other part of our department is now being renovated, and that is where our CT scanner is, which will be incorporated into the renovation. More additional reading rooms, bone mineral density, and also the new area for the MRI, which will be furnished and with a new MRI, hopefully in the very near future.
Great, we can't wait for that MRI.
Yeah.
Great, thank you, Carla. Any questions for Carla from a physician's perspective on what this new space will mean? Everyone's saving their questions to the end. So Carla, you'll chip in, I'm sure, as Laurie's going through her presentation as well. But thank you for that. And I agree, patient privacy is a huge benefit and huge outcome from this latest phase of the redevelopment. So great work. And I know you've been very involved in the design of what this space looks like. So you must be very proud, Carla, of what the result is.
Proud of the Dartmouth General as a whole, really. I mean, this renovation expansion has improved patient care and improved our, the hospital to the level of care that we've always tried to hold ourselves accountable to, but it's great to be in this new space. Yeah.
Great, exciting, well done. Carla mentioned the MRI as well. I see Joe Diab just joined as well. Hi, Joe.
Hello.
Joe was our first donor to the MRI campaign, which we've just launched. So thank you so much, Joe and Violet, for your support. Great to see. Oh, you're on mute there, Joe. I think you. Oh, Joe, you're on mute. I think you're still on mute. There you are. I can hear you now. Perfect.
Okay, I'm very happy to launch that campaign, and I can't wait to see the MRI in the hospital. So any other help we have to do, we'll do it. And I don't know when you're going to start to launch the fundraiser. And maybe I'll talk to you after this meeting.
Great.
About selling tickets for cars or some other idea. I will talk to you later about it.
Great, thank you, Joe. And we'll talk at the last slide. We'll talk a bit about the MRI campaign coming up as well, but we're well into it. So thank you for your support, Joe. Okay, so now why don't we move on to the tour and the demonstration and the visuals. So Lisa, do you want to share the PowerPoint?
Sure thing. I'll bring that up.
Hey, Kim Conrad, how you doing?
I'm doing well, thank you.
Are you selling ice cream today, Kim? And
Oh yeah, I'm advertising the Kiwanis thing in the background.
I love it. Always be selling. Good job. Okay, so we'll now move on to the main event, which is going to be a slideshow, which will give you some photos and kind of inside views of what this latest phase of the diagnostic imaging space looks like. So I'll turn it over to Laurie Harding, who will guide us through, and I'm sure that Carla and Scott will jump in as well. Over to you, Laurie.
Can everybody see that okay?
Yes, I can. Yeah.
Great.
I don't know, Lisa, do you just want to do the slides and I'll speak to what the space is? Perfect. Okay. So what you're looking at when you first come down the hallway from the main lobby, you take a right at the elevators, and this is what you'll see coming up to your left. So this is the first part of our main registration area. Anyone who is getting any diagnostic imaging procedures as well as cardiac investigations will come through and speak with the registration staff. As you can see, we've had our maintenance crews working really hard to get all the plexiglass in place to ensconce all of our beautiful new chairs in our new waiting space to make sure that everyone is maintaining their social distance for COVID. We also have really wide hallways that'll accommodate patients who have mobility issues, maybe in wheelchairs, walkers, those types of things. Those chairs that you're looking at, just underneath the number 1, you'll see taller stools. Those are orthopedic chairs. We have a large volume of patients who have been coming through our ortho clinic, especially since we've been expanding our processes. These are for patients who have had hip surgeries and who aren't able to sit as deeply as normal, so they can kind of perch on the stool and stand up a lot more easily than if they were sitting in a deeper chair. So this is our main registration area.
Lisa, can you go back to the mural as well, the ferry? So I think we're getting great rave reviews of this image as well, which really brightens up the waiting space.
It's
I know
beautiful.
Patients are loving it. Yeah.
We've not worked in a department that's had windows before, so we've got windows and the water. So we're all very excited.
Beautiful, beautiful. Well done.
So that's main registration. Just as you come down the hallway from main registration is our large main waiting area. So what you see above you is a large 40-foot skylight. Again, X-ray techs work in the dark. So for us, having skylight with some natural light has just been such a blessing. We're able to go out and check the weather and absorb a little bit of sunshine here and there. Patients have really been commenting on how nice it is to have the natural light. Same thing, we're still working on the plexiglass to get these chairs separated so far as COVID goes. It's a work in progress. The ones in the back are completed. We're working on the ones in the front. Same thing, we've got the orthopedic chairs for the folks that need them.
Nice.
That brown doorway that you're seeing, that's the entrance to cardiac investigations. So the first third is for our ultrasound and X-ray patients. Middle third for seatings for cardiac, and then the bottom third is for CT, bone density, and mammography.
When does cardiac investigations move in?
They move in tomorrow afternoon.
Tomorrow afternoon, great.
Yeah.
Laurie, I remember the Dartmouth General seeing that long hallway with people waiting in the hallway as I walked by. This is so much better.
Absolutely. And those ambulatory patients will never see our inpatients or emergency patients. As Dr. Pittman was saying, that they'll travel through separate hallways. They have separate waiting areas. Prior to this, we had patients with their little toes sticking out if they didn't have their blankets covered and catheters hanging from their stretchers and those types of things. So to afford them that level of privacy has just been wonderful.
Great.
And their waiting area, actually, I guess we'll talk about that when we get to the slide. What you're looking at now is the entrance to the changing area. There are 3 washrooms at the first, and then when you walk in, there's 4 changing rooms. They're all accessible for patients who may need to go in with a wheelchair or walker, those types of things. Nice, large, oversized chairs. If you need to sit down to put on your shoes, take off your pants, etc. On the other side of that hall, just against the wall, you'll have lockers for patients' belongings to be stored, as well as all of the Johnny shirts and necessary things for patients to change for their exams.
Great.
That is our brand new X-ray room. This is a Siemens EZO Xpree. It was installed in February, and we're just teaching our staff to use it now. We had a week of training with 2 of our super users, and they're transferring their knowledge to the rest of our staff currently. What you're seeing, that tall, I don't really know how to describe it, but to the right of the photo, you see something that's tall, rectangle. That's the one right there. That is something that we've not had at Dartmouth before. We're able to image people with a longer acquisition now. So if we needed to image someone's entire spine, we could do that, where we always had to take 3 shots before to get that. Now we can do it in 1. If there's any questions as to patients' discrepancies of the lengths of their legs, we can image from the tops of patients' hips right to the bottoms of their toes, so that they can do measurements to determine those types of things. So that's really helpful for our orthopedic surgeons for their treating their patients. So this is fully digital. It is the very first unit to be installed in Canada. So it's as new as it gets, and we're very excited to have it.
First in Canada.
First in Canada.
Wow, great.
You can see back there on the last slide, the table sits really, really low to the ground. A lot of our tables, we have to use a stool and kind of get patients to climb up, but this drops really, really close to the floor. So patients who maybe shorter stature or limited mobility, can't climb, those types of things, they're able to just kind of turn around and sit. So that's wonderful as well.
Is the gray tube electrical?
Sorry, is what electrical?
Is the twisty gray tube electrical or cooling, or what?
Yes, that's cables. That twisty gray tube attaches to our tube head. So it's cables that supply that. And yeah, it's power supply for the unit.
Great.
That is our ultrasound work area. As Dr. Pittman mentioned, we have 3 ultrasound rooms with 3 sonographers. So for these types of cases, a lot of times they'll have to look up patients' previous imaging, measure masses or cysts or nodules, those types of things that they'll be following up. So they do a fair amount of research before they bring the patient into their room, and this area allows them to do that. Previous to this work happened in the hallway. We set up a desk and they did those types of things. It was our staff area, but it was still out in the open. So to have a dedicated space is lovely.
That's nice.
This is the inpatient holding areas and emergency holding areas. We were talking about previously, they waited in the main patient hallway. These are dedicated spaces just for patients on stretchers, patients who come from the floors, patients who come from Emerge, who are waiting for general imaging or ultrasound exams. They'll wait here both for their exam to start and to wait to go back to their room. You can see to the left of the photo there, there's head walls, something we never had before either. So if a patient's on high flow oxygen, we're able to maintain their oxygen without depleting their tanks. If they need suction, all of that is there. We can give the patients a call bell. So if something happens and they need assistance, then they can ring for us, which is a tremendous upgrade to what the patients have been experiencing before.
Wow, much better than waiting in the hallway.
Absolutely.
Yeah.
This is one of our X-ray rooms. One of our ultrasound rooms. So what you're looking at is one of our older Philips units. So our oldest unit's about 14 years old. We were fortunate enough to get some government funding to replace one of our units. That just arrived on site last week. So we're doing testing and applications with that next week. staff are very excited for that. As Dr. Pittman was mentioning, we're hoping to start fundraising for another couple of units so that we have 3 units in 3 new rooms. So yes, what you're seeing is the ultrasound unit itself. Most of our patients are ambulatory, so they can come in and lay down on the stretcher and do their exam that way. But we're also able to accommodate the stretcher in the room if the patient's unable to get up. So like Dr. Pittman said, having doors and walls is lovely for privacy for our ultrasound patients. What you're looking at there is the new unit that just arrived. That is a GE Logic 10 2021 version. So we haven't taught the staff yet, but we're all very excited to see what it's able to do.
Great. I know you gave us a demo last week or 2 weeks ago about what the impact of this new machine will be, but maybe tell us a bit about, I think the fleet is, we have a 14-year-old, a 10-year-old, and an 8-year-old, I think, ultrasound.
They're 14, 11, and 10.
14,
yes.
11, and 10, yeah, even older.
Useful expected life is based on usage, and our units are high volume. So expected life is about 8 years. So all 3 of our units are well over their expected life. So we have, you kind of have to determine which patient is the best type of patient for each unit. The newer units are able to better discern smaller masses, nodules, those types of things. I don't know, Dr. Pittman, if I'm not explaining things properly, feel free to step in.
I guess the thing is, if you consider a machine that's 14 years old or 11 years old, you can imagine the advancement in technology in that period of time. And ultrasound really, for us in Dartmouth and at the QE2, is a real workhorse. You know, we use it for so many things every day. What people would typically know would be gallbladders for the pelvis in women, you know, ovaries, uterus, early pregnancy. And as technology has advanced, really the quality of imaging has advanced, and therefore the diagnostic availability increases. And what we with having the machines that we have, which are well past their lifespan, means that sometimes you start a patient on one machine and you really feel that you need better resolution. So we've over the years, we move people around depending on what resolution we feel we need to get the best diagnostic results. And obviously, as we get new equipment, that will no longer be necessary, right? Mm-hmm. So like Laurie said, you would put patients on a machine based on what you're looking at and what degree of resolution you feel you need. We'll no longer have to make that predetermination when we have 3 state-of-the-art machines, right, that are all capable of doing the imaging required despite the difficulty or technical requirements of the patient. So, so these machines will dramatically improve patient care, dramatically.
Great. We are so committed to making this happen for you. So we're actively fundraising right now, so we can't wait. Back to you, Laurie.
Okay, so that's one of our ultrasound rooms.
That's the tour there.
That was it. In addition to those photos, we have 2 other X-ray rooms that are involved with this part of our renovation. They existed prior to our renovation, but they had the imaging equipment was all covered in plastic and the walls kind of were dismantled around them. So one of our imaging rooms was enlarged. They changed a washroom around, those types of things, but the equipment itself is the same as what it was. So that's the other 2 pieces of our department right now.
Okay, great. Well, thank you for that tour, Laurie. We'll go back to questions in a second, but let's talk about this exciting news for the MRI as well. So, as everyone has heard by now, in February, a study was completed, or the results of the study led to government making the decision to select Dartmouth General as the next site for the next MRI for Nova Scotia, based on the population growth here in HRM, the need for an additional unit in HRM, and also based on the Fred Smithers Center for Orthopedic Care being here at the Dartmouth General. The next logical site was to have the next MRI come to Dartmouth. the Dartmouth General Hospital Foundation, we have been lobbying with our physicians to get this MRI selected for Dartmouth, and we have agreed to actually fundraise for the cost of the MRI scanner itself. And the government has just announced that they will fund the operation of the MRI and also the construction and the placement and installation of the MRI over the next 3 years. So we have 3 years to raise the money, and the province has committed to building the space for the MRI. So their investment is about $3.9 million. Our cost to raise the funds for this scanner will be between 1.6 million and 2 million, depending on how quickly we can do it by. And this will be great news. And the government also has agreed to pay for operating it over the next 7 to 10 years. Great news for Dartmouth, so that's fantastic. Carla, maybe you can speak to this a little bit. You were involved in some of the early days of the study itself with Dr. Martel.
Yeah, so this MRI study has been going on for about 5 years. It was just finished, I think, almost a year ago, slightly delayed release because of COVID. If you look at MRI across the province, first you have to look at MRI very broadly. Right now we have an MRI in Sydney, Antigonish, New Glasgow, Truro, Yarmouth, and then 3 at the QE2. If we look from a patient impact perspective, first you can look provincially. If you look at where patients get their MRI done, a significant number of patients from HRM travel to other sites as far as Sydney, but typically to Antigonish, New Glasgow, or Truro to get their MRI because the wait times are less there because of the patient population base. So having another MRI in HRM or the Capital Health will significantly reduce patient travel time to receive an MRI. Then within HRM, why should it go to Dartmouth, I guess is the question. And that really is multifactorial. First of all, we do have inpatients up to 5 or 6 a week, up to 10 sometimes, who require an MRI. And at the moment, those patients have to travel to the QE2. Often they're very sick and very complicated patients. And to be able to do them at the Dartmouth General obviously will significantly improve diagnosis and wait times, because they do then have to wait to get transferred to the QE2 and then back to us. So those patients will be able to have their MRI in Dartmouth. Secondly, you have to think about the Fred Smithers Orthopedic Center. So MRI in terms of orthopedics really is the standard of care now across North America and Canada. So it really is essential that having an orthopedic center of excellence has an MRI. So, we're very excited. It really is an integral part of having an orthopedic center. So that's another reason that they recommended it for Dartmouth. And also even outpatients in Dartmouth, we service Hants, Musquodoboit, and Dartmouth, and those patients can now have their MRI within their own community. So it will not only decrease wait times across the province, but also within, HRM, and really it will transform care at the Dartmouth General in so many ways.
Great, so exciting. Thank you, Carla. That was well said. So Laurie, tell us a bit about where this is going to be going. I see John McLeod just asked a question about, will it fit? What are your plans?
Yes, it will fit. When the designs were made for our new space, it was made to fit an MRI suite in here as well. So we're keeping our existing footprint, still keeping our same complement of imaging rooms, those types of things, but adding an MRI. So it's all been planned. We've got the space ready for it. We just need to put the machine in it.
Exciting.
Yes, that was wonderful future planning for the engineers.
Good thinking. Okay, great. So let's move to questions then. Maybe we can move off the presentation, Lisa, and we can go back to full screen and open the floor to questions. Any questions from anyone based on what you heard today from the team? You can just wave your hand up or write a question in the chat box if you'd like. I know that Jack, you had a question? Yeah. Go ahead, Jack. If you want, you're on mute there right now, but if you want to click, you're off mute. Yeah.
Yes, hear me now?
Yes, perfect.
What's going to be the cost of these imaging machines, the ones that you need to replace?
The ultrasound machines?
The ultrasound.
Yes.
Yeah, Laurie, do you want to take that one?
Sure. We are, there's a provincial contract right now. So the vendor, they do contracts for every 3 years. So if a unit needs to be bought within the province, right now it's a GE unit. Each unit is $143,600, taxes included.
Does that include training and so on with it?
Correct.
Yes. Thank you.
You're welcome.
Laurie had that right off the top of her head, exactly to the dollar. I love that.
I like numbers.
That's great. Great question, Jack. And these both ultrasounds are included in the men's health white paper and also the women's health white paper. If you've taken a look at that, these are key parts of our health white papers right now. So, and the board is committed to make this happen. Go ahead, Jack. Yeah.
I've got one more if you can spare me time.
Yes, of course.
The new imaging machine, MRI, is it a standard size or is it a larger size? Is there 2 different sizes?
Good question. Laurie or Carla, to take that one?
The sizes of them, to my knowledge, are fairly standard. Different machines have different Teslas, I guess. It's hard to describe, but this would be the similar size to any other units that are in HRM.
Jack, you're talking about in terms of patient size as well?
The patient, and for patient size, because I know that there's been occasion that people had to leave Halifax, Dartmouth and go to Truro because their machine was newer and it's larger. So is that to do with the age of the machine, or?
Well, as machines improve, they take into account the changing of patient demographics. So previously, the weight limit for an MRI may have been 300 pounds. I haven't been an MRI for quite some time, so I'm not sure what the weight limit would be for someone now, but I know that when they make new equipment, we call them the gantry size or the bore size, which is the tunnel that the patient would fit in, gets larger to accommodate those types of patients.
Okay, thank you.
You're welcome.
Carla, I think you're on mute, Carla. Yeah.
There. Good? Yeah.
Yes, I can hear you now.
One thing I will comment on, which Laurie mentioned when she talked about size, she mentioned the Tesla of the MRI. So basically that's the strength of the magnet. So when you talk about size of an MRI, you could also be talking about the strength of the magnet. So we would be getting a 1.5 Tesla MRI, which really is a workhorse, a clinical use MRI. There is a 3 Tesla in Halifax that's actually used for a 50% research. So a 3 Tesla machine is more of a research-oriented machine, and we'll be getting a 1.5 Tesla, which is considered, a clinical use diagnostic MRI.
Great. That's great information. Thank you, Carla. Other questions? Thank you, Jack, for that one, or those 2 questions are really good. Lisa, I think we had a few questions come in earlier. Do you want to?
Sure. In terms of the ultrasound, you mentioned that it was a workhorse. How many patients would you see on a daily basis with one machine?
We book patients based on the sonographers rather than the machine itself. So Sonography Canada recommends that sonographers don't image more than 15 patients per day. And that's because of shoulder strain, arm strain, those transducers that they need to press onto patients. You have to really get in there sometimes and press hard to see what you're trying to see. So we need to keep to Sonography Canada's guidelines, which is 15 a day. We have 3 sonographers, so that's an average of about 45 patients each day.
Great. And can you tell us a little bit about the difference between what an ultrasound does, what an X-ray machine does, a CT scan, and MRI? Like, what are the differences? We know they scan, but what do they really do?
Each machine has its own specialty. So MRI is really good for soft tissue types of things, tendon injuries, ligament tears. So far as orthopedics go, that would be one thing. Scarring, if they needed to see anything like that. So MRI isn't really great for bone. It's really great for anything that isn't bone. Strokes in the brain, Parkinson's disease, those types of things. Organs, MRI is great for. What's important about MRI is it doesn't use any radiation. So that's a wonderful bonus as well. I don't want to hog things, Carla, so if you want to jump in, help yourself. X-ray is a two-dimensional view of the body, so it sees things, everything is kind of stuck on top of each other. So if you take a view of someone's abdomen, you can't really differentiate the kidneys from the liver, from the spine, or from the pancreas. When you do a CT exam, we cut a patient we slice them like they're a loaf of bread. So we can see the liver separate from the spleen, separate from the stomach, separate from the spine. So we can get a nice separate view of all of the patient's anatomy rather than have it all compressed on top of each other like a regular X-ray. So they both use radiation. Sonography uses sound waves. So there's no radiation involved with that as well, which is another wonderful benefit for sonography. Same thing, they're really good at soft tissue. So like Carla was saying before, gallbladders, they see, gynecological issues with women, prostates, thyroids. If it's not a bone, ultrasound checks it out.
I think what Laurie basically has told us is that diagnostic imaging really is a multimodality practice. So you might not use you would not use an ultrasound to look at bowel, but you may use a CT. You would not use necessarily an MRI to look at bowel, but you would use a CT or fluoroscopy sometimes if you're doing an enema. Ultrasound looks best at gallbladder, CT does not. So it's not like, a lot of people think the higher the more glamorous the technology, the better it is. All of our machinery and what we use has the capacity to look at different things in different ways. Yeah.
Great, good to know. I see we have a question come in. What are the daily operating hours for the department?
Our first patient is booked for 7:30 a.m. and our last outpatient is booked at 6:45 p.m. for CT. After that, we have emergency and inpatient care for X-ray and CT.
And that's through the evening, through all night, okay.
And overnight, yes.
And overnight.
The CT technologist is on call, but if it works out that the X-ray tech that's working also does CT, then there's no need to call someone in to do the CTs.
Great. Any other questions?
Laurie, I think during the renovations, we were running evening hours. How did that work out?
Yeah, we started the evening hours because we couldn't keep up with the demand with our smaller space. With the renovations, we went from 4 imaging rooms down to 1 new room that was generously funded by our foundation, as well as a very old CR room, which is a technology that uses X-ray plates, so they still needed to be processed. So our ability to image patients decreased a lot. So we had to do all of our orthopedic clinics and our emergency patients and inpatients during the day, and we shifted our outpatient X-rays to the evening. It worked out well. It was a challenge. Our staff had to change their hours. They worked a lot of evenings over the last bit when the renovation was happening. But we did get some positive feedback from patients that they liked coming in the evenings.
Great. Some good learning. Other questions? Any other questions, Lisa, on
I have one here. What's the percentage of patients that are walk-in versus inpatient, or I guess outpatient versus inpatient, or
good question.
coming in from Emerge? Or
Well, everyone is booked now with COVID-19. We had to drastically change how we handled things. So the walk-in clinics stopped and we started booking patients just so that we could try and socially distance our patients better. So far as inpatient volume, I'd say our inpatients are about 10% of our work. Emergency patients, they're a lot higher. I would say probably 15 to 20%.
Great.
Great. I think I saw a question from John there on the chat.
It says, did COVID reduce capacity of imaging, or is just made your scheduling tighter?
We had to change how we imaged our patients. It most definitely affected our department because we had to, everything got plexiglass so that we could socially distance our patients. With the renovation, we went down to half of our department and we had seating for about 55 patients pre-COVID. After COVID, we had seating for about 25. So we couldn't have more than those numbers of patients in our department, which made things tough. We had to look at scheduling ultrasound differently from bone density, differently from x-ray, to try and have patients showing up at different times to try and keep the waiting rooms as empty as possible. But no, we kept imaging the same volume of patients. Once we picked back up after the first wave shut things down, we just had to space them out.
And our staff really has rallied, you can comment on this, Laurie, in terms of, you know, we've been catching up on the wait list and they really have been working exceptionally hard to rebook all the patients who had to be canceled because of COVID earlier in the year.
I think the unsung heroes of this pandemic has been our booking staff.
Yeah.
Oh my stars, those ladies, they handle the phone calls and all of the questions, and there's thousands of consults to be booked and dealt with, and they've just handled them like champs. Yeah, really proud of our staff.
Great. We're really proud of you all as well. Amazing work. So please pass on our thanks to your teams.
Will do.
Incredible. Incredible. Other questions, other thoughts? It's so exciting to have this come to Dartmouth. John? Yep.
Okay, not really an imaging question, but as the hospital gets towards the end of the major renovations, have you been able to drive down the orthopedic wait times at all?
Oh, good question. I know we're still catching up from COVID, but Scott, do you want to talk about that one and in terms of some of the wait times and the larger redevelopment impact?
Oh, hi. So in terms of the wait times, obviously during COVID, surgery was canceled for a while and then it was brought back at reduced capacity. And we're still not at 100% capacity, mostly because of bed capacity. For the last few months, we've had over 100% occupancy, and we're just getting up to 100% of our surgical volumes. And we're running extra ORs when we can and trying to catch up, but we definitely haven't caught up to where we should be with orthopedics. And the plan is that in December, when we get the extra beds and we have the 8 ORs operating, we'll have 2 rooms every day just doing joint replacements. So that will be 8 patients every day having a hip or a knee replacement. And that will be a significant increase. And that's really where we're going to cut into that wait time very, very quickly.
Thank you.
So once all 8 operating rooms are in place and we have the extra beds from 5 West, that should help us. Scott, talk a bit about the long-term care home domino effect. Why are we so full?
So we're trying to figure out why we're so full. It's impacting our site and also the Halifax Infirmary. One of the problems is long-term care. So during COVID, all the long-term care homes were very reluctant to accept patients, and because they're worried about what if someone gets COVID, how are they going to isolate them, protect the other patients? So the easiest solution was to not accept patients and to keep those patients in the home. The other problem was with a lot of the long-term care homes, they had shared accommodations with more than 1 patient in a room, which isn't really acceptable going forwards. So a lot of the long-term care homes have had to renovate, make single rooms, and what they've done is reduce the volume of patients they can take. So I think going forward, there's going to have to be some investments in long-term care and building more homes and building more of the care at home strategy. Because currently what's happening is we're having a lot of patients who end up in the emergency department because there isn't the availability of care at home. Patients who could probably stay at home and get care and then go into a long-term care home at the appropriate time. Because the long-term care system is maxed out because of COVID too, and a lot of those patients are ending up in the emergency department and getting admitted. And once they're admitted, they're in the hospital for a long time. And so often we have difficulty finding a home to transfer them to, and they end up in the hospital. So currently, I believe we have about 20% of our acute care beds are housing long-term care patients. So it's a real problem because an acute care hospital isn't the best place for a long-term care patient. Often they have to be more isolated in their room. They don't have the availability of the social network, group activities, group dining, things like that, which they have in a long-term care home. So it's not good for those patients, and it's not good for the patients who need acute care services, which is really what the hospital is designed to provide. So Gordon and I are working on that and coming up with some strategies and working with the government too, to try to get the long-term care homes to feel comfortable so they can accept more patients and ultimately get more funding to build more long-term care homes if that's deemed appropriate.
Great, thank you, Scott. So you can see that there's a domino effect that's at play here as well, John. But when we have the 8 new operating rooms open, we will be able to start to tackle these wait times. Other questions?
Can you talk a little bit more about the X-ray unit? You mentioned it was first in Canada. Can somebody discuss that a little more?
I'm not sure what you guys want to know. It's a digital unit, which means that we don't have to use any type of post-processing. It's much like your digital camera. Once you take your X-ray, the image pops up after a second or two on our screen. So it's definitely a lot faster than our previous CR technology. What's nice about this, for us to take our images, we have to go back behind a leaded glass to protect ourselves from the radiation. So we have to kind of leave the patient a little bit to go back and shoot our image. This unit has a camera on the tube itself. So what the tube is pointing at has a camera that points at the patient. So we're able to see a photo of the patient's outsides as well as their insides, if that makes sense. So it's a little bit of extra security for the patient. Let me see. It's like I said, the table goes really low. So for patient comfort, we're able to do that. We talked about the capabilities of doing, we can X-ray up to 36 inches with one acquisition, which is something we've not been able to do before. Previously, those patients have had to go to Cobequid or the IWK or Halifax to get those done. So we'll be able to service the patients from Dartmouth, their needs for those types of exams, which we couldn't previously do. What else? Am I missing anything, Carla?
I think that's it. I mean, the digital technology has been, just as in our everyday life, really has revolutionized what we do. So now that it's digital, it's computerized, and it comes immediately, almost immediately, to the radiologist for viewing. So that's a huge improvement, has happened over time, but the digital technology has really improved patient care. It takes a lot less time to image and no processing time really to send us the images. So
something that's also nice about digital images is we're able to what we call window the images more. So if we take an image that might be a little bit too dark or a little bit too light, we can add post-processing to it so that we can alter the image without having to take extra shots for the patient. So it decreases the repeats, which decreases the radiation to the patient.
Well, great. Thank you very much, Laurie, and thank you, Carla, and thank you, Scott. Any final questions, Lisa?
One last question. With the increase in demand in other departments, they're doing more procedures with their orthopedic center and stuff. Has there been an increased demand in imaging as well?
Year over year, we always increase. CT, for instance, we book 31 patients a day, and our average throughput in CT is about 60 patients a day. So we almost double what we book every single day of the week. So there's always the demand. with extra orthopedic patients. We're doing extra OR cases, which leads to more patients needing follow-ups for those types of exams. When I started here 15 years ago, the average throughput for the department was about 200 cases a day. I just did the math before this started, and we're up to about 340, 345 patients a day. So we're definitely operating at full.
Wow.
Yeah.
Incredible.
Oh, sorry. I was just going to add to that. That has to do with our capacity issues as well. I think as you look at Dartmouth and Halifax, the population is expanding, especially in Dartmouth. You just have to look around at the hospital at all the apartments and condominiums that are going up and all the people who are moving into those, presumably from outside the city. So we're going to have more people utilizing Dartmouth General, which is good, but we just have to have the capacity to deal with that and have the right technology.
That's right. Well, great. Well, thank you, everyone. Thank you so much, Carla. Thank you, Laurie. Thank you, Scott, for this really informative overview and tour, virtual tour. If anyone wants to get a real live tour as well, just give us a call. We can arrange for a personal tour if you want to go behind the scenes in person. And thank you, Lisa, and thank you, Kiana, and thank you to our foundation staff for pulling this together. And wow, we're just so impressed with our frontline staff, and Carla and Laurie and Scott, what you guys are doing is so incredible. So thank you, thank you, thank you. You know, every day you're pulling miracles here, so we really appreciate it. And thank you to our donors. Thank you to all of the donors who have made this happen. Your donations have been matched 10 times over by the province. For our $13 million goal, we've exceeded. The province has invested $137 million for this $150 million project. So thank you, thank you, thank you to all of our donors for making this a reality. Our next milestone will be in June as we open the Lorraine Brownrigg ICU. So again, hopefully we'll be able to give you a tour of the Lorraine Brownrigg ICU in person in June. And if you have any questions on the MRI campaign or on the men's health white paper or the women's health white paper, please feel free to reach out to Lisa, Tom, Nina, or myself, and we'll be more than happy to answer your questions on those initiatives as well. Thank you, everyone, for joining us tonight, and it's been really informative. Thank you, Laurie, and thank you, Carla, and thank you, Scott. And everyone stay safe, and we'll talk soon.
Thanks, everyone.
Thank you.
Thank
Bye-bye.
you. Bye-bye.
Thank you.
Thanks.